Today we are discussing the history taking of a patient with vertigo. Vertigo is a very important complaint and many patients present in neurology OPD with complaint of vertigo, and it is also very important to differentiate the peripheral causes of vertigo from central causes of vertigo. So a comprehensive approach is very important to evaluate patients presenting with vertigo and dizziness. So we will discuss it. Start it with open-ended questions. What exactly do you feel? Is it spinning, imbalance, lightheadedness, blackout feeling? If spinning sensation, patient is having true vertigo. If patient is feeling faint, it is presyncope. If patient is feeling unsteady walking, it is disequilibrium. If floating sensation, then non-specific dizziness or anxiety. Then ask patient about onset of symptoms, whether symptom onset was sudden or gradual, it is first episode or recurrent, triggered vertigo or spontaneous vertigo. If sudden, severe, continuous vertigo, vestibular neuronitis or stroke is likely. If there are recurrent brief attacks, then BPPV. If episodic vertigo with hearing symptoms, must think about Meniere's disease. So onset of symptoms is very important. Then duration of vertigo, seconds duration, benign paroxysmal positional vertigo. Vertigo lasts minute to hours. Think about Meniere's disease, vestibular migraine. If vertigo is of hours to days, think about vestibular neuronitis or labyrinthitis. If persistent chronic vertigo, think about central causes or PPPD. So duration of vertigo is very important to reach at a conclusion. Then triggering factors. Ask patient whether turning in bed, looking upward, sudden standing, head movement, loud sounds or stress triggers vertigo. If there are positional triggers, these strongly suggest BPPV. So triggering factors are very important. They tell us about the most common or more probable etiology. Then ask patient about associated air symptoms like hearing loss, tinnitus, air fullness, air discharge, air pain. If patient is having vertigo with fluctuating hearing loss and tinnitus, think about Meniere's disease. If patient is having vertigo with hearing loss after infection, think about labyrinthitis. So associated air symptoms differentiate vertigo from central causes of vertigo. Then neurologic symptoms like diplopia, dysarthria, dysphagia, facial weakness, limb weakness or numbness, ataxia, severe occipital headache, loss of consciousness. If these symptoms are present, they suggest stroke or central pathology like cerebellian, brainstem pathology or multiple sclerosis. So asking about neurologic symptoms is very important. Then headache and migraine history. If patient is having history of migraine, photophobia, aura or headache is associated with vertigo, then you must think about vestibular migraine. So if chronic headache with vertigo, you can think about vestibular migraine, especially when there are no other neurologic symptoms. Then we will ask patient about recent infection or trauma. Ask whether there is any viral illness, fever, air infection, head injury. If these symptoms are present, they indicate vestibular neuronitis, labyrinthitis, perilymph fistula. So viral infections, fever, air infection, head injury tell us about probable diagnosis of vestibular neuronitis, labyrinthitis and perilymph fistula. Then ask patient about vascular risk factors like hypertension, diabetes, smoking, dyslipidemia, ischemic heart disease, previous stroke or TIA. Because if vascular risk factors are present like hypertension, diabetes, smoking, dyslipidemia, ischemic heart disease, previous stroke, TIA, we will must think about posterior circulation stroke. Then ask patient about drug history like aminoglycosides, antiepileptics, sedatives, alcohol, antihypertensives because patient may be having drug induced dizziness or a drug induced vertigo. And because some drugs are vestibulotoxic like aminoglycosides, they induce chronic vertigo without any associated neurologic symptoms. Then ask patient about functional impact. What is the functional impact of vertigo on life of patient? Ask patient whether he can walk independently. If there are any associated falls, patient is able to work or not. Is patient bedbound or dependent? It will tell us about morbidity and gravity of the problem, that how severe is vertigo and what can be the probable reason, and how aggressive intervention is needed. Then ask patient about past and family history. Ask regarding migraine, past history of stroke, past history of ear disease, autoimmune disease. Migraine with vertigo, you will think about vestibular migraine. Stroke with vertigo, you will think about central vertigo. Ear disease with vertigo, you will think about oral vertigo. If autoimmune disease with vertigo, you will think about MS, multiple sclerosis. Then ask a patient about psychological symptoms. Patient may be having psychogenic vertigo. Ask about anxiety symptoms, panic symptoms, chronic subjective dizziness. If psychological symptoms are present, patient may be having persistent postural perceptual dizziness or PPPD and anxiety related dizziness. When patient is having no neurologic symptoms, no oral symptoms, must think about psychological or psychogenic vertigo. If brief position vertigo, our diagnosis will be BPPV. If continuous acute vertigo after viral illness, we will think about vestibular neuritis. If vertigo with hearing loss tinnitus, we will think about Meniere's disease. If vertigo with neurologic deficit, we will think about stroke or central vertigo. If recurrent vertigo with migraine features, we will think about vestibular migraine. Then we will ask patient what worries you most about this problem. Have you fallen recently? Any recent worsening? What medications or treatments have you tried? We have asked these questions previously, and if patient having some special worries, history of trauma, recent worsening, medication or treatment, it helps us to reach at the most probable cause of vertigo. So these questions are very important. We will have to differentiate. And then red flags are very important, like new neurology deficit, gait ataxia, diplopia, dysarthria, sudden deficit, severe occipital headache, high vascular risk patients, which indicate any probability or possibility or differential diagnosis of posterior circulation stroke. So asking a very good history of vertigo, like psychological, psychogenic, oral and neurologic symptoms, is very important to reach at a proper diagnosis of vertigo.